Well, thanks for having me. I apologize for putting neurosurgery in the title because I know we go by cranie and spine here. This has been a great discussion so far, and all of these are difficult questions. A lot of them don't have really great, straightforward, easy answers that you can pull from the literature. And so we practice in a combined setting of what's in the literature and what we know from experience. And actually where I was going to start with is whenever I come to talk to a group like this, because of all of that gamish that we work with, people always have a lot of questions for how we work. And I'll just start with a couple of comments about the Jehovah's Witness, because here at Swedish, our department is structured under the title of Blood Services, and that includes three major groupings, one of which is blood management, one of which is the transfusion service, and one of which is bloodless medicine. And we do have a strong bloodless medicine program here. We are sought after in the Jehovah's Witness community, being the largest group of patients who refuses transfusion, but there are patients who refuse it for either other religious grounds or personal grounds for a variety of reasons. And like Dr. Chapman mentioned, I think we owe these people the utmost of respect, whether we agree or not with their decision. I cannot tell you how many patients I've seen who somebody tries to twist their arm about needing to be transfused, and I agree that's an ethically dangerous place to go, especially for people who have this on religious grounds, because they're weighing their ever after against this moment, and very often they are, in fact, willing to accept going to the ever after rather than be transfused. Having said that, there is a wide spectrum of what they will accept. In general, the directive from their faith is to not allow for blood, which is what they call major components, plasma, platelets, and red blood cells. All the other aspects of blood, including minor components such as cryoprecipitate, albumin, anything else that's made from blood, they are allowed a personal decision, and they typically do this in consultation with their faith leadership at the local level. So you'll see a broad spectrum of choices there. Many of these patients will accept cell saver, particularly if there's continuity throughout, as long as whatever blood is leaving their body stays connected to their body. So they don't want it to go off to a machine and be centrifuged over there and then brought back to them. As long as they're always connected, then they consider it to have not left their body, and they will accept that. So just as a starter. And then the other thing you brought up is cell saver, and we are working on some internal guidelines. Over the last year, the peri-op or the anesthesia services have been implementing a whole lot of new instrumentation just to update their instruments. So they've been really focused on that. But just like for everything else in healthcare, they have a newer system out there for quality assurance and compliance, and it's a very large programmatic change for them to implement all of that. So once they get a little bit more settled there, we are going to be very actively looking at getting information out that everybody can use about indications for cell saver use. And so you mentioned not using it in the setting of infection and malignancy. Those are pretty classic contraindications with some variations allowed. And the other is just, when is it useful? So if you're not going to be able to collect more than X amount of blood, setting the whole thing up seems oftentimes to be not worth the while of doing it, weighed against what you anticipate in terms of blood loss and being able to maximize return of that blood to the patient so that you minimize transfusion. So those are some good things I think we already came up with. Anything else you want to start with? Okay. I'm just going to run through a bunch of stuff. We'll pay attention to the time, and we can talk more another time because there's always a lot to cover here. So I thought we would just take a stepwise approach here. When we think about identifying our patient preoperatively, one of the best things we can do is to identify, diagnose, and treat anemia. Anytime you have an elective case, this really should be done in a world-class patient blood management, and that's the lingo, patient blood management, or PBM, in a really world-class program, people have suggested that, for instance, OR scheduling, even a visit to the surgeon, should not be allowed until a patient has been assessed for anemia and a workup and initiation of treatment when indicated has been done. And we've seen, particularly in cardiac surgery here at Cherry Hill, a number of patients for whom this turned out to be a critical diagnostic step and actually helped the patient to avoid surgery altogether in terms of changing the diagnosis. Obviously you need time for all of these potential consults, testing, treatment. Iron deficiency is by far the most common, and in patients older than 50, we always have to think about the potential of colon cancer. So if iron replacement isn't sufficient, then we have to think about other things like that. And in some patient groups, erythropoietic agents like EPO are good options. People are always concerned about risk of thrombosis with this, and so it's a pretty tightly controlled medication situation, and there are limitations as to who can prescribe it and things like that. But we can often work around that if it seems truly indicated. So what kind of blood bank testing do you want to do before surgery? So to my mind, what we typically do is a type and screen. The type refers to the group and type, which is ABO and RH. The antibody screen is your critical result here. So this means, do you have an antibody against some red cell antigen? Anytime you have one of those, it makes it harder to find blood. And we have to specifically pull a unit off the shelf that is negative for that antigen so the antibody won't interact and cause hemolysis. All of that takes extra time. If the antibody is against something that's a high-frequency antigen, that means the prevalence in the blood supply is a low-frequency event, and it becomes hard to find those units. If you need many of those units, it becomes even harder. And if there are multiple antibodies, it becomes even harder. So this is really your critical result, and that's one of the reasons that we recommend doing this testing if possible, before the day of surgery, because you really, really do not want to have a patient scheduled for 7 a.m., send a type and screen at 6 a.m., get a positive antibody result back at 7 when you're planning to go to the OR. It is at least 1 other hour at minimum to finish this workup. And then finding blood could be who knows how long. So, and if it's a complicated workup, like multiple antibodies, we're talking several hours. And if it's something that turns out to be complicated, for instance, by rarity or complicated by a warm autoantibody, we could be talking about a full 24-hour day to complete this workup. And if we're talking about really rare blood, we're talking about multiple days to get it in, oftentimes from anywhere across the country. So this is an absolutely critical result. Yeah.
One quick interruptive question. Is it true that the more transfusions patients have had, the higher the likelihood of antibodies is? I mean,
Yes.
as a general rule of thumb.
Yes.
So if one of those polytransfused patients, the susceptibility for quizzical or difficult matches rises.
Yeah. So in the general population, about 2 to 3% of people have an antibody. In a multiply transfused population, that goes up to 5 or 6%. So it's still not a high percentage, but it's a pretty significant amount of work that we do. And like I said, it has a really critical effect on your day, because it's going to blow your day out of the water when you run into that at 7 in the morning. In addition to knowing somebody's type and screen, which in order to transfuse, we have to have what's a current in-date type and screen that's defined by the FDA. These are not all of our rules, too. We're not the bad guys here. We have to do these things, like this is in law. A current in-date type and screen is defined as 3 days, and unless we have some medical reason to make it something different. And also, in order to do a cross-match for most of our patients, we're required to have a second specimen to confirm the ABO and RH type for that patient. And this is a real pain in the neck also to deal with, because particularly if a patient is presenting as a new patient, so they have no history, both of these samples have to be drawn typically on the same day, and nobody wants to go and draw the patient again for an ABO confirmatory sample. But it's really important. The single largest reason to have a hemolytic and acute hemolytic transfusion reaction is that we gave the wrong blood type. And 99% of the time that we give the wrong blood type, it's because we started with a mislabeled specimen. And so the whole point of this confirmatory specimen is to go back to the patient for a second time, reconfirm their identity, checking their wristband, things like that, and making sure you have the right label on the tube. So these are our transfusion indications. I'm guessing most of you are not aware of this, but we do have this available in Swedish standards. And these are pretty standard. There are slight variations in this around the country, but in general, they're pretty on point. And they get updated from time to time. This is available in Swedish standards under blood management. And then I also wanted to mention these patients with hematologic malignancy, because these patients should get irradiated cellular blood products, which are red cells and platelets. And the reason for this is that irradiation of the blood component makes the lymphocytes that are present in there unable to replicate and therefore unable to cause transfusion-associated graft versus host disease. This type of graft versus host disease is fatal in something like 95 to 99% of patients. So it's clearly something we do not want to give somebody. Anybody who has an underlying hematologic malignancy, including things like aplastic anemia and myelodysplastic syndrome, all your leukemia and lymphoma patients and myeloma patients should get this. As a safety net here at Swedish, we will apply irradiation even if you don't order it, if we know the patient has one of these diagnoses or is in a cancer treatment unit in the hospital, which we see a lot more at First Hill, for instance, than here. But I know you guys do a fair number of surgeries on patients with lymphoma and myeloma, and a lot of times we're not seeing the irradiation in the order. So it's important for us to take care of that. When you place an order, so we're doing the, is this a pointer? Oops, yeah, look at that. A type and screen test. So you want to do that when you think that there is some good reason that you're expecting to need a blood transfusion. And then you might have to, for us it's Epic, but in computerized order entry systems in general, cross-match means prepare the product. And transfuse means give the product. And so these are the kinds of languages, wording that you'll see in different systems. And we, in fact, have it in ours. I think in our current version of Epic, it's called cross, match, and hold, if you're just ordering a cross match. And then, so how do we prepare for surgery? So if you think that transfusion is not very likely, then on our transfusion consent form, you would mark it as not likely, and you don't really have to do anything else. You don't do a type and screen, you wouldn't do a cross match, and you wouldn't be getting blood for the OR. If you think it's possible, and this is basically a low risk for a transfusion situation, that's obviously something you still want to talk to your patient about. So it's a good time to get transfusion consent and do a type and screen, but you probably don't have to go beyond that. And then if you think it's highly likely, then obviously you want to be discussing it with your patient, getting consent. You want to do that type and screen. And if you just think you might need some blood in the course of the surgery or post-op, there's no real need to cross-match it until such time as you need it. If a patient has no antibodies, blood is ready in about 2 to 3 minutes, and we can get it by tube down to the OR in another couple minutes. So for most cases, that's sufficient. If waiting 5 to 6 minutes is not sufficient, that's when you want to cross-match in advance. So when you were talking about preparing all this blood before surgery in a case, that's the guiding principle that we would apply. Is that if you need it in less than 5 minutes, by all means prepare it and put it in the OR. If you can wait 5 to 10 minutes, then just call us when you need it. Yeah.
I have more than once had a situation, let's just put it down at 7 p.m., where we had ordered blood, and the minutes, the half hours go by, and nothing has happened.
Yeah.
What should we do?
Call the blood bank. Just call.
Just call.
Yeah, so...
Who do we call? Who specifically?
Call the blood bank lab. So you're going to get a tech, a medical technologist. So we get a lot of orders that are placed stat, and stat is by definition 1 hour. So if we just get an order that says stat, we're going to fill it within an hour. But if you need it in 10 minutes, you need to tell us that. The only way we are going to know that difference is if you actually call us. And just to speak to that point a little bit further is if you have no blood bank testing and you have a patient hemorrhaging who needs blood right now, same thing, give us a call because we're going to walk you through. Oh, you don't have a type-in screen? That means you're going to get on cross-matched group O. You do have a type-in screen, no antibodies, we're going to give you cross-matched blood in 2 or 3 minutes. And all of that relates to this having double-checked the patient's ABO and RH, and the fact that we can do what's now called an electronic cross-match. It's the patient's blood type is in the computer, the unit types are in the computer, and the units are checked 3 times before they ever make it to inventory in a blood bank. So to make sure that their label, it says O or B or A or whatever it is accurate. So then it's a matter of scanning, and this is why it's so fast, because it's just like being at a grocery store. You can scan the unit and match it up in the computer with the patient, and if they are compatible, it will spit out a label. The longest time phase of doing this is actually printing the piece of paper out on the printer. So it's fast. And what do we have on site? Just so you know, we have red blood cells, we have platelets, we have plasma and cryoprecipitate. Platelets, we might have pooled platelets or apheresis platelets. These are used interchangeably. There's not a lot or any significant difference in their clinical use. It's just a matter of how they were collected. And they are considered a dose. So a pool of platelets is a dose, which is equivalent to an apheresis or single donor platelet. So you don't have to account for the number of units in a pool of platelets. So if you order 6 platelets thinking you're getting a pool of 6, we're going to freak out because we're like, what? You want 6 doses of platelets? That's crazy. That's, you're going to get a call from us right away. What do you mean by that? What's really going on with your patient? Plasma, we commonly call it FFP for fresh frozen plasma, but these are blood bank terminologies based on the manufacturing process. How fast after collection was it frozen? So you might actually see plasma that's been frozen within 24 hours on the label, which is called PF24. It's all thawed by the time it gets to you, and this changes the name according to the FDA, and we have to label it and so on. In addition, we have liquid plasma here, which has never been frozen, and because of that, it's irradiated, again, to protect against the activity of those lymphocytes that are present. Just so you know, as you mentioned, we do talk about monitoring, and we're really hovering around our infancy of having a good monitoring program, and this is partly because of how we've had to develop our monitoring, our data resources, and now they all got blown out of the water and they're getting redeveloped now that we just had Epic instance alignment. So we keep getting thrown back to square one here. But what we see when we look at this department specifically is that when we look across providers for every single procedure, we see that it is routine for a type-in screen to be ordered for all types of cases. So, and then what we also know by experience, even though it's not written down anywhere we can find, is that we receive a lot of stat orders on the day of surgery pre-op to have blood available in the OR just in case for a lot of blood that we do not end up transfusing. And that goes back to this whole idea of ordering it when you need it, only cross-matching it when you need it at the time you need it. And so we see a lot of these units come back in. We have had a massive transfusion protocol under the name of Code Hemorrhage for a couple of years here, and recently we've turned it into a true massive transfusion protocol under that name. It's available in Epic now as an order, and nurses have been trained on it. We're still getting out some physician education, and we'll be coming around doing some unit-based orientation and training also. But just so you know, and when you mentioned this balanced resuscitation, this comes out of trauma trials. Harborview specifically published the most definitive, most recent paper on this called the PROPER trial, and they found that this ratio, which is a 1-to-1 ratio, so 6 units of red cells to 6 units of plasma, 1 unit of platelets, meaning 1 dose of platelets, and 1 dose of cryo. Again, the platelets or the cryo come in pools, so that's a 1-to-1 ratio across there. The idea is that you do this empirically until such time as you can get lab results, and then you follow your lab results to continue your resuscitation. In general, we're not looking to get people back to a normal hemoglobin. We're looking to get them above 8, but we probably don't have to go as high as 10. We want their platelets to be at least 50 and somewhere in the 50 to 100 range. Oftentimes 100 is the goal in your field. And INR doesn't, again, have to be totally normal, but we would like it to be less than 1.9. And fibrinogen, the classic textbook teaching is to have fibrinogen over 100. What we know by experience is that 150 to 200 is better in our surgical cases. And I actually just noticed this morning that the reference range of normal on our fibrinogen here at Swedish went up recently. So I would veer towards 200 for our surgical cases. And what I would say I see in our bleeding patient populations is that is the most overlooked test. We don't see it ordered as often as we need it to be ordered, and we don't see it repleted by cryotransfusion as much as we would like. And again, I mentioned before, the volume overload related to transfusion and trying to fix things. If you fix your fibrinogen with cryo, which is a low volume product, all of these other things work better. And so you'll have to give more plasma if your fibrinogen is lacking than if you replete that fibrinogen. So I feel really strongly it's one of the most important things, and it's easy to do, to stay on top of that fibrinogen count and make sure you're supporting it with cryo as you need. So the way our MTP is set up is that we divide that one-to-one transfusion into 2 rounds, which then alternate until you tell us to stop. A lot of the hospitals in this region use a boxed set, and you order it as many times as you need it. We opted to make it a little easier and just call it a faucet on, faucet off MTP. You call us to get that superstat notification. Within 3 minutes, we're going to have the first round ready for you. It's going to be 3 units of red cells and plasma and a platelet. And then it's going to keep going. And it takes a little while. We keep that plasma always thawed. That's where the liquid plasma comes in. The additional plasma we have to thaw. So that takes 10 to 15 minutes. But you'll get these products as they're available. So the second round completes the 1-to-1 transfusion ratio for 6, 6, 1, and 1. And then this is just going to keep going. So you'll have products continuously available until you tell us to stop. Now, of course, we're not going to keep preparing dozens of products if you're not coming to pick them up. So we will call you and say, are you done, if you're not coming to pick them up. And this does require a runner. Here at Cherry Hill in particular, and also at Issaquah, there are shifts where we only have one staff person. So we need that person in the lab getting the stuff ready for you and not carrying it around the hospital. There really has to be a runner. Every one of these gets reviewed, and we get back to providers who ordered this thinking there might maybe someday be a massive hemorrhage in the differential diagnosis of this problem I'm dealing with, and they order this. The other thing is, do not use it if you just need something fast. Going back to this point, if you just need a couple of units of red cells fast, MTP is not the way to order it. Just call the blood bank and tell us when you need it, and we'll get it for you. Transfusion consent we already mentioned, and I really just wanted to leave it here as a placeholder because we've been through so much churn with it in the last couple of years. And I'm not going to go through all of this stuff, but your major risks here are reaction and infections from transfusion. Some people think we should include or add to our consent form the increased risks for post-op infection, increased length of stay, and immunomodulation, but we haven't moved quite to that yet. In addition, since EPIC instance alignment, there's new language in the blood transfusion order set about consent, which we are hotly pursuing across the Providence St. Joe system. So I don't know what else to say about that other than it doesn't apply to us yet. In terms of practice monitoring, in a quality system, we all have to do this, and these are the kinds of things that we would look at. Nationally and internationally, people often look at the so-called cross-match to transfusion ratio, which is a number like 1.3. So I don't know what you think, but I think that's hard to understand. What does it mean if I'm transfusing 1.3? But if you flip that ratio upside down as a transfusion rate, 70% of what you order should be getting transfused. And if you are well under that, then you're probably over-ordering for any kind of product. So we need to look at what's ordered, what's transfused, and We also look at the rate of single red cell units. We don't have to have a knee-jerk reaction to always order 2, and in fact, 1 is enough for our patients. And since we are strictly out of time, I'm just going to take a couple more minutes and touch on the topic of what about the ICU versus the surgeon and the anesthesiologist. So our ICU docs are really well-versed on the current literature about the benefit of conservative transfusion strategies, and that has been shown across a broad variety of patient groups for a stable, hospitalized, non-bleeding patient, where the hemoglobin threshold is 7, your INR threshold is 1.9 or thereabouts, et cetera. And the question is, what about the surgical patient? What about the immediate post-op window versus a day or 2 later? And this is where I think you're most likely to get into discussions around what exactly is going on. I think, to my mind, the main thing is that blood or transfusion of any blood component is not necessarily the answer to a lot of soft findings. And so if you think about it in a fairly conservative or stringent kind of way, I think that's helpful to everybody. We know that transfusion affects patients negatively in a large number of ways. It affects their immune status, it affects their survival, their length of stay, risk for infections, and it has effects like this over long periods of time going into the future. So really, anytime you have the opportunity to reasonably not transfuse, that's probably a favored approach. So you really have to think about transfusion as a support for something a patient specifically needs. And so I'm just going to leave it there generically. I see you probably have a comment, and maybe others do too. Yeah.
That's actually a subject I want to bring up because it's, as you mentioned, it's frequently a point of contention between surgeons and particularly intensivists. Anesthesiologists tend to vary in their criteria for transfusion. And I think if you look at the data from TRIC and other, medical patients where acute blood loss is, an exclusion criteria, the data definitely favors conservative transfusion measures. It's my understanding that if you look at the FOCUS trial and other trials in surgical patients, the data is more ambiguous. FOCUS, I think, found no difference in terms of outcomes in patients with cardiac risk factors going hip replacement with a transfusion threshold of 8. And in all of these trials, there's an exclusion for symptomatic anemia, which
Right.
I think is the biggest gray area. What in your mind constitutes symptomatic anemia, especially given that these patients have fluctuating intravascular volumes, which can
Right.
either obfuscate or falsely present with elevated or low hemoglobin levels?
For me, I think tachycardia is a really good sign. I think using something like fatigue, which has been presented to me several times over the years, I think that's a pretty soft one. I mean, you're tired after you've had surgery, and it's kind of hard to judge that. So something like fatigue or even ability to get through rehab. Some people have said over time that just empirically, if somebody's hemoglobin's higher, they're going to do better at an exercise challenge. And that may or may not be true. There is some literature in orthopedics suggesting it might be true, but it's not great. It's just not really out there as a standout solution. So I think in your immediate post-op care, especially, I think tachycardia is a really good sign, especially when you've ruled out a lot of other issues. Blood pressure, I think, is a little harder to cite specifically, even though a lot of people do. The patient's hypotensive, and we don't really know why, therefore we want to give blood. What we see with transfusion is that it doesn't seem to affect the blood pressure a lot unless we send somebody into volume overload, in which case their blood pressure goes up.
Thank you.
Thank you for coming. I mean, to be continued, the main thing is I
Yeah.
really appreciate you being so responsive, personally available. That's a big culture difference from where I came from, where this was a very anonymous kind of a ethereal entity. So having a face, having a very kind of obviously highly knowledgeable partner in this, whose understanding of where we're coming from is really important. And again, evolving our discussion facilitated by yourself with our anesthesiology and ICU colleagues would be my request, because again, this is something that's still an ongoing friction element. And again, I think that there's probably an overemphasis from my perspective on the ACS, the American College of Surgeons data, which we think does not necessarily apply to us.
Yeah.
But again, these are very valuable insights. And again, having the troubleshooting, bailouts, the information is very important. And hopefully we can continue that actually in a cell saver focused discussion far more in terms of when should we use it, having more guidance about the financial implications. Does it actually save blood transfusions or not? So those are the main things. I'm a believer, but again, having guidance, having your big picture perspective certainly helps. Any other questions? Otherwise, thank you everybody here. My team, our teams here who came, fantastic. Rod, any other thoughts?
No. Thank you for coming.
Sure.
It's been great working with you guys, and I think, it's amazing to see how much has evolved since I've been here. I mean, we really didn't even have a blood bank on campus.
That's so good to hear.
When I first started, it was like 911 when we needed blood. So I remember cross-matching type and screening every patient because I would just lose sleep over, all these cases. And now I think you've done a great job. So appreciate all that you've done.
Sure. That's good. So I just want to say thank you to everybody, and really a lot of what I put up here is somewhat basic, but I know people don't have a sense of familiarity with it. And really the bottom line is if you have any questions or issues or discussions that are getting contentious, by all means, just give us a call. We'll be in touch. So thank you.